Chief Instructor. She'll be talking on phacoemulsification in vitrectomized eye, what a surgeon should know. Dr. Kalai is a senior consultant in cataract surgery, cataract services at Girdhara Institute. Over to you, Kalai.
Thank you, Dr. Sandhya. Good morning, everybody. My talk is on phacoemulsification in vitrectomized eye, what a surgeon should know. Why it matters? Because there is increasing number of posterior segment surgeries, there is a rise in post-vitrectomy cataracts. And cataract develops in 65 to 80% of the eyes within 1 to 2 years after PPV. And cataract surgery in vitrectomized eyes improves vision in more than 85% of the patients. And mechanism of cataract formation: once the vitreous gel is removed, oxygen from the retinal circulation diffuses into the posterior chamber and is in constant contact touch with the lens, oxidizing the lens, forming cataract. And the bright light from the fiber optic probe can also give rise to cataract. And direct capsular injury during the PPV can give rise to traumatic cataract. And tamponade like silicone oil and gas again can give rise to cataract. So preoperative evaluation is very important. History is very important. The indication for the PPV is important because the visual prognosis depends on the indication of the PPV. Slit lamp examination is important. We have to look for the pupillary dilatation, posterior synechia, zonular weakness, phacodonesis, and pre-existing PCR, etc. And do a OCT to know the macular status, and a fundus examination in case of opaque media. And if the cataract develops within 4 months after PPV, you have to suspect a lens touch. IOL power calculation challenges. Axial length requires foveal fixation, and that is the main source of error in patients with macular pathology. And staphyloma or high myopia adds to this challenge. Optical biometry is preferred if fixation is adequate, and IOL Master 700 there is an integrated OCT system which can align well with the foveal fixation. So axial length measurement will be accurate in IOL Master 700. In case of opaque media, ultrasound biometry can be used. Biometry in silicone oil filled eyes. In case of mature cataract, we can use the optical biometer with silicone oil mode. But in case of dense cataract, we have to go for the ultrasound biometer. But in our center, we take the axial length of the other eye. Intraoperative concerns. Once the PPV is done, the vitreous cavity is filled with fluid. So there is no gel support during the cataract surgery. And the anterior chamber is deep and unstable, and the pupil is usually not dilated, and there will be synechial formation with weak zonules and excess lens mobility. So if you give a retrobulbar or subtenon's anesthesia, we can that increases the volume around the eye, thereby minimizing the sudden deepening when the probe is introduced. And capsular access is challenging because we have to put more pressure on the anterior lens capsule to initiate the capsular flap. And big rexis is recommended because sometimes you have to bring the nucleus out of the bag. Trypan blue is again recommended, and while injecting we have to be slow because it can diffuse into the posterior chamber. While initiating the rexis flap, if it is too hard, we have to suspect an occult zonular dialysis. Hydrodissection can be done in uncomplicated cases, and if you are suspecting a posterior lens touch, hydrodelineation should be done, and nuclear rotation should be gentle. The lens capsule complex moves with every fluid pulse. So sculpting in these cases will be very difficult. So nucleus removal should be done with chopping techniques as shown in this video, and a slow motion phaco should be carried out. There's something called reverse pupillary block, which usually occurs in PPV cases. The laxity of the lens iris diaphragm The pupil border gets stuck into the anterior capsule, and the fluid gets trapped in the anterior chamber, and the pupil gets dilated, and the maneuver becomes difficult. In such cases, the iris should be lifted. In the video you can see the iris should be lifted off the anterior capsule to reverse it. Pupil often constricts once it is reversed. So again you can see you have to lift the iris off the anterior capsule. If PCR happens, the lens should be brought out of the capsular bag, and lens scaffolding technique should be employed to lower the risk of dropped nucleus. Because the PCR happens, there is nothing like vitreous prolapse because there is no vitreous here. So we have to protect the nucleus from dropping down. So this lens scaffolding technique should be employed. Again, that is the placing the 3-piece lens in the sulcus with optic capture, and once the lens is placed, we can remove the nucleus after that. Capsular tension ring can be used if there is any sonular compromise. Cortical removal is again difficult in these cases because of the poor sonular stability, and because the capsular bag wobbles, and bimanual irrigation aspiration helps in such cases, and high chances of dialysis is there during IA. If the bag is intact, we can place a single piece IOL in the bag, and if there is PCR, we have to place the 3-piece IOL in the sulcus with optic capture. This video is to show how optic capture is being done. The IOL is placed in the sulcus, slightly rotated, and my zonular dialysis is there in this area, but the IOL is stable, and now the capture is being done. Just push it behind the anterior capsule. That's it. Complication management: if there is nucleus drop, retrieve the nucleus via plas plana, and if there is no capsular support, scleral fixated IOL can be used, or iris claw lens can be used. Postoperative complications include cystoid macular edema, recurrent retinal detachment, posterior capsular opacification, and late IOL dislocation. So to summarize, cataract surgery after PPV improves vision in majority. Understand the altered chamber dynamics and fluidics. Accurate biometry is critical, and modify the surgical technique to minimize complications, and monitor for CME, RD, PCO, IOL displacement. Thank you.